So just a little bit of background. So I'd like to just tell you guys a little bit about the GGPC, because about 60% of the doctors on tonight are from our collaboration, and the rest are people who are visiting with us tonight. We're really glad to have you. The GGPC is the Gauteng GP collaboration. It was formed by Dr. Karen van der Merwe in 2015. It's a group of doctors who most of whom don't know one another. We haven't met one another. Some of us have, but most haven't. And we don't represent any organization and certainly are not affiliated really in any way. But we work together just in terms of offering support to one another, first on a WhatsApp group, but now it's grown into various projects in terms of educating, in terms of building support, in terms of just, in this pandemic, really putting our minds together to learn and to grow and to support one another. So we're really grateful tonight to have the people who we have on, who've now coming onto our fourth panel to teach us about COVID-19 and help us to really just answer some of the pressing issues in our mind. So our panelists tonight, and I just want to make sure that I've made them all co-hosts. Prof. Mer wasn't on it yet, so I just want to see if he is now. Here he is. I'm just going to make him on as a co-host. Okay, great. So our panelists tonight, and I'm going to try and make my speaking really limited tonight to give people time, because we've got a very busy panel. But we're joined by Prof. Salim Abdul Karim, who is not a stranger to many of us. He's the head of the Presidential Advisory Committee for COVID-19. We also joined by Prof. Harvey Risch, who is a well-known epidemiologist at Yale University in the US, and he joins us from the US. We're joined by Prof. Mervyn at Joburg Gen, where he lives these days. He's there at the moment, helping us, with patients clinically as we talk. And we joined by Dr. Brian Levy from Netcare Rosebank Clinic, who's in the private sector running the ICU there. Also a very active clinician who was very involved with patient management for a lot of us. So thank you so much for all being part of this. What I'm going to do is I'm going to suggest that we start with Prof. Karim, who will give us an overview of just where we're at in terms of this pandemic. I'm going to, just without getting, spending too much on this time on this, I'm going to say that just Prof. Karim is a prof of clinical epidemiology. He's done a lot of research in HIV, women and HIV, which was really a big part of his research that he was really involved in now, just in having had Women's Day. He's a infectious disease specialist. He's been recognized for his contributions in these fields. And he's the chairperson, as I said, of the SA COVID-19 Ministerial Committee. So we're really grateful that in this busy schedule that he's given up this time to speak to us. He's the director of CAPRISA, and he's really a global leader for our country. So without spending much more time wasted, let me hand over to him, and we look forward to some insights that he can share with us.
Thank you very much, Dan. It's a great pleasure and an honor to be with you here today. I'm just going to share my screen so that you all can see. Can I just check, Dan, that you can see my screen?
Perfectly, yep. I can see it perfectly.
Okay, great. So when Dan asked me to come and speak at this group, I said, what can I tell a group of clinicians who have much more experience in treating COVID-19 than I do? Well, I said, well, I can share with them just some perspectives of where we are in the epidemic and give some impressions about the state of the play and to give some idea of where we are going. So let's start by looking at what our curve looks like. What you are looking at is a 7-day moving average of the new cases occurring each day. And if you look at it, what becomes patently obvious is that we had very few cases each day up to more or less, the end of April, middle of May. And then from the 1st of June, when we eased most of our restrictions, about within a week or so of that, by June the 10th, the epidemic was starting to rise. And so we hit this high peak here of around 12 to 13,000 cases a day. And now over the last 2 weeks or so, we've steadily been coming down. So this is the picture you're familiar with. Now, why does it have this kind of picture? Well, this diagram helps. So if you look at this diagram, what becomes clear is that up to the beginning of June, the black line was principally influenced by the green line. The green line is the Western Cape. So all the way from the start to pretty much the first week of June, our epidemic was almost entirely based on, not almost entirely, but largely based on what was going on in the Western Cape. The Western Cape had its epidemic much earlier. At the tail end of the level 5 restrictions, we started seeing outbreaks. They occurred principally in the supermarkets and in the grocery stores. Stores like the Khayelitsha Spa, there were about 37 cases identified there. At the Woolworths, at the Delft supermarket, there were just, tens and hundreds of cases. And so what happened in the Western Cape is these small outbreaks that occurred in these grocery stores and supermarkets then seeded the epidemic in the general community in the Western Cape. And so the Western Cape took off before the rest of us, before the rest of the country. Now, when you look at the situation from around the 10th of June, what begins to dominate the picture is the red line, and that's Gauteng. So as you see Gauteng rising, so too does the black line. The black line is influenced now mostly by Gauteng, but also is pushed up by the green line, which is the Western Cape, and the blue line, which is the Eastern Cape. So in combination, we see this rapid increase. The peak of the epidemic nationally is heavily influenced by Gauteng, and then so too is the decline. Now, as it stands, our epidemic is now predominantly being influenced by KwaZulu-Natal. That's the orange line. So the orange line has hit this kind of peak. It's now looking like it's coming down, but it's still early days. So when you look at the overall picture of the epidemic, it's actually a mosaic of epidemics in the different provinces, all occurring at different rates, at different times, in different ways across the board. And you can see that KwaZulu-Natal, is way behind the pack. The Western Cape always wants to do things first. The Gauteng wants to do things big. And of course, KwaZulu-Natal will bring up the rear. So that's how these three provinces' epidemics have shaped our overall black line curve. So how confident are we that the actual epidemic is on the downswing? I mean, that line looks pretty convincing, but can we really be sure that it's not just going to turn again? Well, one indicator we use is the proportion of positive tests. And at our peak, we were at about 26% of the tests we did were positive. In other words, roughly 1 out of 4. Right now, we are close to 1 out of 5. We're just above 20%, but that's still pretty high. We would want to get closer to the 10% range, where we're doing 10 tests to get 1 positive. And that's what, at that point, we can be much more confident that the curvature is definitely on the downswing. If we look at how it relates to admissions, because admissions is a key component, a really good marker. These bars that you see at the bottom, that's the 7-day moving average of the number of admissions in sentinel hospitals that contribute to the DADCOV database. Now, so it doesn't comprise all hospitals, just sentinel hospitals. There are several private sector hospitals that are part of the Sentinel program, but much fewer public hospitals. When you look at, again, our usual black line that you're familiar with now, when you look at the way in which admissions occurred at the peak of our cases, we were also peaking in terms of the number of cases, and the number of cases has now steadily been declining. And you can see that over the last 2 weeks or so, admissions are progressively getting less and less. And actually, you speak to any of the doctors in the hospitals, whether in Gauteng or in Western Cape, or even in the Eastern Cape, they basically are saying, yes, you know, the number of admissions has eased quite substantially. In fact, they even have free beds now available. So what can we see from all of that?
This, please listening. Sure.
The number of cases is declining. The number of admissions is declining. The proportion that's positive is declining. So all told, we have quite a promising trend, but it's still a little bit too early to be definitive. I think we just need a few more days of data and we'll be much more confident. So is the worst over? What's our risk of a second surge? So if you look at the South African line, it's a bit different from what you would have expected. Let's go down to Spain. Spain followed what was, you know, the usual sort of curve you expect. Very shortly, so all of these graphs for all 4 countries, they all start with day naught being the day on which the first case was identified. So that's day naught. And then they all go up to day 162. So just to give you some idea that they all standardized in the X and Y axis. So they are directly comparable. So if you look at Spain, what happened was that the number of cases rose rapidly to close to 10,000 per day, and then it slowly eased down and it's come to the simmering point. And that's more or less the epidemic you see in Spain. If you look at the epidemic in Germany, again, the same situation. Germany is regarded as one of the countries that did the best, or among the best, not the best, but among the best in terms of controlling the spread of the virus. Within a matter of about 2 weeks after their first case, the number of infections rose rapidly. They reached a peak of around 5,000 cases per day, and then it settled down, and now it's at this low level simmering away. If you look at South Africa, one of the things that's striking is we didn't have that early bump. You know, that as soon as you identify your first case, you would expect a rapid rise. We didn't have that. And part of the reason for that, in all likelihood, is that our very early interventions in declaring the state of disaster, stopping international travel, closing the schools, and so on, all of those activities together with the lockdown had the net effect of essentially instituting a sort of an extreme form of social distancing through the lockdown. And so we didn't really see the spread of this virus very early on. And so when you look at the way in which our epidemic grew, it sort of took a much more scenic route. It took a long time to really gather steam and gather momentum. And then when it did, it took off at just over 10,000 cases per day and then started coming down. The problem is that when you look at several other countries that have had this kind of picture and have been at this kind of stage in the epidemic, this could quite easily turn upwards. How do we know that? Well, let's look at the US. In the US, they had this peak that went up to around 30,000 cases per day. And then from that peak, they started declining and they were coming down, and then suddenly they flattened and took off again. And now they are in the midst of their second surge. It's still part of the first epidemic, but in the second surge. So we could quite easily, if we ease our restrictions unwisely, or if we start not wearing masks and doing all the important prevention activities, we could end up with a situation where this could turn upwards. And so we're not out of the woods yet. If you look at Spain, they didn't have a second surge directly after their first, but they're having it now. So if you look at this increase that has occurred over the last week, Spain is in the midst of a major outbreak of the coronavirus, and they are now in the midst of their second wave. So how do we, what do we say, or how do we try to analyze our situation and say, is the worst over? The answer is no, not yet. We still run the risk of a second surge at this stage, directly linked to our first surge. Let me end off with just two interesting studies published over the last few days. This is a study that looks at super spreading events. So using phylogenetic data, phylogenetic means just looking at the genetic sequence of the viruses, using that data in Israel, combined with looking at another study, a completely independent study using cell phone data from Hong Kong. Both these studies suggest that about 10% of infected people may lead to about 80% of the new cases in certain situations. I mean, that's quite striking, because it means, even if the majority of the individuals are following the rules and maintaining their social distancing and maintaining and wearing their masks, even a small proportion of people could lead to a continuation of the spread of the virus. And so it becomes important that we try and do better and have more people following the rules. And in this particular analysis that was done, they gave examples from several different settings of how the virus can spread. So if you take, for example, religious gatherings, there were 15 super spreading events across several countries. On average, one person in a religious gathering can infect 23 other people. Just giving you some idea of the hazards of religious gatherings. You can see I talked about the Kailicha Spa and the Woolworths. The shops, there have been several reports of super spreading events in shops where one infected individual can infect 20 others. And of course, we all know that one of our biggest challenges is prisons. And in the 4 outbreaks that have been described officially, that a single infected individual can lead to 226 infections within the prison. As we've seen in the Eastern Cape, in the West Bank prison, one warder who went to a funeral and acquired the infection at the funeral comes back and spreads it to nearly 70 people at the West Bank prison, including about 30 odd other warders who then took it to their families. So you can imagine how, one individual can lead to an outbreak and push the numbers up quite rapidly. And then I thought I'd share with you this interesting study in last week's Journal of Infectious Diseases. It sort of corroborates the issue that we sort of thought was the case. And that is that in the presence of normal sunlight, so this is simulated sunlight, but let's just go with the fact that, go with the extrapolation to normal sunlight. So if this is in normal sunlight, about 90% of the viruses are inactivated within 7 minutes in simulated saliva. So it gives you some idea that actually the virus doesn't do too well in sunlight. On the other hand, when you start getting into a situation where there's darkness, here you can see that for hours the virus remains viable, and the virus is continuing to remain viable in saliva for quite a while. So the sunlight is our friend. As many things as we can do, we should do in the sunlight. In fact, in Europe, as you know, in the restaurants, they only allow to open their restaurants with the tables that are outside in the sun. So I thought I would just give you some impressions of where we are in our epidemic. We are at a critical stage. We cannot afford to become complacent. We've got to continue our efforts. And if all goes well, and if there's no super spreading events, we should be in a situation where within the next week or two, we will be much more readily available to, possible to say whether we are now clearly over the surge and in the post-surge decline. So I hope that's been helpful to you, and I'm happy to take questions in due course. Thanks, Dan.
Thank you, Prof. Very helpful and quite encouraging. I mean, I must say, I don't know if I would have suspected 2 weeks ago that I don't know, 3 weeks ago that we would have been in this case, in this position now. There are a lot of questions coming through about the curve, where we're at, what to expect. I'm going to move on and not waste time because I know these questions are going to come to you soon. So let me move on. Just a couple of points of order, just for the new people on the panels who haven't been on there before. We do have a Q&A as we go through the evening, more towards the end. So if you do have questions, please feel free to put them in the chat. I will ask a couple of my colleagues to help me if there are a lot of questions to help group them. I'm very pro patient doctors being seen on these panels, and that's why we've done them as meetings, not as webinars. So if you want to see what each other look like, you're more than welcome to screen through. So I encourage people to put their cameras on, and when you ask your questions, if you want to use your camera, just write there, I'll ask or I'll talk. And when we come to the question, we'll spotlight you like I'm being spotlighted at the moment, and we'll be able to see who you are, and you can ask the question live. And just make sure also when you ask the question that it says that Dr. whoever you are asking to everyone and not just to me, so that people can see one another's questions. Okay, so moving on, thank you for that, Prof. We'll come to you soon again. I would like to come to another Prof, and that's Prof. Harvey Risch. Prof. Harvey Risch joins us from the US. He's in the US at the moment, where it's 2:00, 2:30. He is a professor of epidemiology at Yale University. He's a professor of epidemiology and public health at the School of Medicine. His interests were initially in cancer, etiology of cancers. He's done a lot of research there, and he has been very involved in COVID-19, and he's been very vocal in COVID-19. He's previously he's a professor who's put out a lot of papers, peer-reviewed studies. He's been an author of over 300 studies. And in the US context, which is obviously very different to South Africa, there's been a lot of discussion about early treatment, maybe even more so than in South Africa. And he's been a very big proponent of certain modalities in terms of COVID treatment. Certainly from the beginning, he's been very pro the use of hydroxychloroquine, and that's something that he's been very vocal about continually, with Zithromax, zinc. I won't steal any of his, I've read a bit of his stuff, but I'll let him talk about that, obviously. These are subjects that we looked at in South Africa as well, and continue to. Obviously, there's been a lot of research that's come out, some in support of it, some against it. And when I looked at the beginning of including this type of subject matter, I did get some questions as to, well, if we're already seeing research that shows that this does or doesn't work, like why do we want to debate this on this forum? And after speaking to a few of my colleagues, I thought it's really important for us as doctors to understand that, Prof. Barry Shub from the NICD said to me, there is no expert in COVID. COVID hasn't been out for long enough for anybody to say that they're an expert in COVID, whoever they are. And it's important for any clinician to be open-minded and at the same time to be unequivocally committed to a process of evidence-based medicine, to be unequivocally committed to principles of doing no harm, and to be absolutely committed to the will to make a difference to people's lives and not harm them at the same time. So, you know, it's important to engage in these debates, even if they aren't that clear cut at the beginning. So to open our minds to hear another point of view, I think is very important, especially if we can learn from it and grapple with some of the issues. And if I can, well, what I'll do is I'll ask Prof. Risch to address us for a few minutes, and then very briefly, I'll just introduce Prof. Mervyn, who will, without responding to Prof. Risch, I'll ask Mervyn to engage with him in a bit of discussion about what he's presenting. So without much further ado, let me hand over to Prof. Risch.
Well, thank you very much. It's an honor and a pleasure to address everybody today. I almost got into this whole field by accident. But as it turns out, after medical school, I did my PhD in mathematical models of infectious diseases. I published a paper or two 40 years ago in this, and then I got turned on to doing the cancer research that I've been doing for almost the rest of my career. But early this year, I got pulled into a committee that I'm a member of the Connecticut Academy of Science and Engineering, and the Academy formed a committee to advise the governor of the state of Connecticut about reopening after we had survived some initial phase or phases of the epidemic. And this committee was what he called an out-of-the-box kind of committee that involved engineers, a few doctors, mathematical modelers, social scientists, and so on, to try to come up with some novel ideas about how to manage the epidemic in Connecticut. And as I read things that were sent to me by my colleagues who had already started learning about COVID, I realized that the hospitals were rapidly filling up with cases that were very difficult to treat, and the mortality was very high in them. And so it seemed to me the obvious thing was, how could we keep patients out of the hospital in the first place? And in doing some research, and now we're talking about March, April, I became aware that there were doctors reporting amazing success with medications for treating people and keeping them out of the hospital in the first place. And so I started to do research on my own. I'm basically a scientist. I'm very unswayed by opinions. I've always been one to go to the basic papers, the research, wherever I can find data, synthesize the data on myself. I barely trust myself, and that tells you how much I trust everybody else telling me what I should believe. And so I went to the original studies and tried to figure out what they were saying. And in collecting everything that I could find everywhere, and because COVID is such a rapidly evolving disease and science, I felt that it was important to find data from anywhere that anybody had reported it, try to judge for myself, to act as my own peer reviewer of what these papers were saying even before they were peer reviewed, which is what was happening. And in reviewing everything that I could possibly find about treating outpatients, it quickly became apparent that everything was pointing in one direction and one direction only, which is that medications, including hydroxychloroquine and what I'll call companion medications, that includes zinc, azithromycin, perhaps doxycycline, and now we have evidence for steroid usage as well in outpatients, reduces the risk of hospitalization and reduces mortality risk. And I said, okay, well, that's good, but what about harm, potential harm? And I started looking for data dealing with the suggested side effects or adverse events that occur with these medication usage. We have two sources for this kind of data. The first one in the United States is the FAERS database, which is a database of adverse reports that are spontaneously reported to the Food and Drug Administration, the FDA, which collects all of these reports and posts it in a large database that anybody can go to the website the FAERS dashboard, public dashboard, and query the database for diseases that you're interested in, outcomes that you're interested in, medications that you're interested in, years that you're interested in, and so on. And so I did that, and the suggested negative outcomes were cardiac arrhythmias, ventricular arrhythmias in particular, test-dependent, and ventricular arrhythmias in general. And when I did that, I found that for hydroxychloroquine, there were very few. The numbers that I found for all collected arrhythmias that could possibly be related to hydroxychloroquine use totaled 1,064 for the period of medication usage from 1968 to early 2020. So we don't have an exact number of people and prescriptions over that period, but we know that it's at least in the billions and probably a number of billions of usage. We have reports, these are reports that are submitted by patients themselves or doctors or pharmacists that probably underreport the real numbers that are occurring by 10 or 20-fold. And so we're talking about in the 1,000 or 10,000 of these adverse reports for billions of usage of the medications. And the FDA also classifies these reports as to fatal reports or other serious reports. The fatal reports were 200 out of 1,064. So 20% of these reports were fatal arrhythmias. And that struck me as being very disproportionately low compared to the deaths that have been occurring during the same time. Now, the Oxford group at the same time did a study of large medical records database of people who use hydroxychloroquine as part of their regular everyday treatment for rheumatoid arthritis and other conditions. And what they did is they went to 14 large national or almost national kinds of medical insurance records databases, extracted all the patients who had been have rheumatoid arthritis diagnoses, and then saw what drugs they were using. And so they were able not only to look at hydroxychloroquine use, but hydroxychloroquine plus azithromycin use in the same people at the same time. And what they showed, and the data they showed for this is in the supplements to their paper, which are available online. They showed that the increased risk of cardiac arrhythmias was negligible for people using hydroxychloroquine plus azithromycin. So this is what I wrote about in my first paper at the end of May in the American Journal of Epidemiology. I basically took all the evidence that I could find that was available anywhere, bearing on usage and hospitalization or mortality outcomes, and adverse events in cardiac arrhythmias, and just described all of that. And so that was the gist of it. And then I had a kind of creative writing section to this paper at the end, where I thought, well, why are people disagreeing with this? Why are the basic scientists saying that they only want randomized controlled trial evidence and nothing else is good enough? And why are epidemiologists like myself saying we summarize all of the evidence to date, we come up with a pattern, the pattern is very clear, why isn't that convincing? And it occurred to me that some of the reasoning might have been that everybody believes their own studies and their own data. So basic scientists believe that their laboratory studies are meaningful to them, and they're willing to extrapolate to humans because they think their laboratory studies are definitive. Whereas epidemiologists believe that their epidemiologic studies, when done properly, when adequately controlled for confounding and biases and so on, they believe in those kinds of studies, and therefore the extrapolation to humans in general, not just to the people in their studies, is warranted. And so I posited that there was a disconnect between the way people view their scientific disciplines. Well, that was probably an understatement of the year, even though it seemed interesting to me at the time. In any event, this has evolved over time since I published that paper. It certainly got a lot of notice, but the point of the paper and what I've observed since then is that if you look in the people who need to be treated early, the evidence is all one-sided. So what do I mean by the people who need to be treated early? We define in this disease low-risk patients and high-risk patients. Low-risk patients are people who basically will survive the disease with discomforts, but not any life-threatening illness. These are people, at least in the United States, it's more or less defined as people under age 60 with no chronic conditions like diabetes, obesity, uncontrolled hypertension, immunocompromise, status post-cancer diagnoses, and so on. People who are basically healthy, youngish kind of people. These people do well. They very rarely need to be treated. The treatment in them occurs because in a very small number, rarely, they will develop shortness of breath. When at shortness of breath in very light activities like walking around the house, if that happens, they need to be treated. They become high-risk people and they need to be treated. High-risk people are people over 60 or with these comorbidities. You can see this in the United States by looking at any state's mortality according to age groups. You see that under age 60, the lines are all at the bottom of the graph. There's almost nothing to be seen there. Whereas as you go to age groups over age 60, the mortality explodes, especially in the older age groups among them. That's what defines high-risk patients, patients with diabetes, older age, and so on. So those are the patients that need to be treated early. And this was a principle that was defined very early in this disease. This is not a subgroup that was cherry-picked. This was defined as part of the clinical approach to treating the patients that need to be treated back in March, April. Okay, so when one looks in these patients who need to be treated and are treated early before they get to hospital, those are the ones where the medications are uniformly successful. That is the group, the patients who need to be treated, who get the treatment early. And studies of those people, there are no studies of those people that show lack of benefit of these medications, especially hydroxychloroquine plus zinc plus companion medications. There are no studies, to my knowledge, to date, published showing in those people who need to be treated, who get treated early, that the medications do not work. What we have instead is a number of randomized trials of patients, outpatient usage of the medications in general. And those outpatient trials, like the ones from the University of Minnesota or the ones from Catalonia in Spain, looked at healthcare workers by and large. And in those people, most of them are under age 60, they're mostly healthy, and they're all almost entirely low-risk patients. And what you see in low-risk patients is you look in their control groups, in their untreated groups, the placebo groups, and there's nobody who's hospitalized. Very, very few people are hospitalized. It proves that they're low-risk people. So there's no point in treating those people because they do well on their own, and there's no room to do better because they're already doing well without the treatment. And for that reason, those studies do not bear on the evidence for treating high-risk people. The one exception to this is one of the studies in Spain where it happened that a small number of the people that were included in, this was a randomized cluster study, a small number were patients who were living in nursing homes. And in them, their risk of the bad outcome from the study that the study looked at, their risk was cut in half with usage of hydroxychloroquine. So this is an entirely universal phenomenon of medication effectiveness in the people who need to be treated when they get it early. And it does not extrapolate very well to other people who don't need to be treated or who are already in the hospital, by and large, when it's too late for this so-called antiviral property of the medication to work after day 5 to 7 of their symptoms. Then the effectiveness of the medication wanes and the evidence is mixed at best. Some studies have shown benefit at that point, some not. And but it's too late. Basically, it's too late to use that medication as a primary rationale for treatment. The medication works in high-risk patients when they're treated early. And so I'm a scientist. I'm not saying I have any vested interest in this. I want dying to stop. And this is what works in the people who are at risk of dying. And so I've just made that case. The people who push back on that message have been ones who conflate the people who need to be treated. At first it doesn't work, period. Not saying whether it was inpatient use or outpatient use. When I've been forthright in saying you have to be clear that this is early use, it doesn't apply to hospital use. Then they conflated low-risk people with high-risk people. They said that the randomized trials, which are supposed to be the gold standard of evidence, show that it doesn't work. In fact, not only do the randomized trials not say that, but they're looking at the wrong people. They're not addressing low-risk people versus high-risk people. In fact, even now, there's statisticians in Brazil who've created an open letter to say that the authors of these randomized trials have misinterpreted their own data. They've shown that the outcomes in the trials have been statistically not significant. But that's not the reason why the trials say what they say. The trials actually show small amounts of benefit in the treated groups, but they're not significant because the trials were either cut short or because they weren't big enough to show the benefit when the patients themselves were at so low risk that there wouldn't be any outcomes to start with. So every way around this, when one looks clearly and defines the people who are at the risk of actually having the outcomes, those are the people who are benefited, and that's why the case is very clear. Is this the only treatment regimen that works? No, by no means. There's evidence for other drugs too. But at least one has to start somewhere, and that's where I've been and why I've been saying the messages that I've been saying. So thanks very much for listening. I'm happy to address questions.
Thank you, Prof. Very interesting. I know there's a lot of questions on this. I'm not going to waste much time, so I'm not going to address the questions myself, other than maybe to ask you just something simple at the beginning. One thing, and then I'm going to hand over to Prof. Mer, is perhaps just a yes or no answer at the beginning. Is, do you believe that the reason for a lot of the backlash against hydroxychloroquine and azithromycin and zinc, without getting into any of the detail of it, is because of the political loadedness of the situation in America? In other words, were it not connected to the politics, do you think that the current situation would be different?
I
Do you
think
want to maybe go ahead.
It started earlier. It started before President Trump made his statements. So the political is a component of it, but it's not necessarily the only or the main one, actually.
Okay, great. We'll come back to more. Okay, so let me then use this opportunity to go back to Prof. Mer. When I say back, Prof. Mer is not a stranger to this. Sorry, I'm just going to get myself on here again. So Prof. Mer is no stranger to this forum. On our previous meeting, we were very blessed to have Prof. Mer speak to us. Prof. Mer is a critical care specialist at Johannesburg Hospital. He is a pulmonologist and intensivist. He's at Joburg Gen at the moment, where he spends most evenings past 11, 12 o'clock, as do a lot of our specialists and even doctors who are on here tonight, not at Joburg Gen, but in their own fields. And he joins us there tonight. I'm very grateful to have him again. And, I asked him if he could engage with Prof. Risch just on some of his thoughts about this matter. And again, for the people who went on at the beginning, I think the important part here is, do we rely on observational data? Do we insist on randomized controlled trials given the current situation? And if not, and we are prepared to go on observational data, obviously we want to do no harm, where do we draw the line? In other words, what are the downsides of just trying this experimental stuff? We don't want to leave, the purpose of tonight is not to leave a meeting as clinicians saying, I'm going to go out and start writing out hydroxychloroquine from tomorrow, but it's to understand what one's approach should be in this type of situation. So let me hand over to Prof. Mer, and then we can engage in a bigger Q&A at the end.
Thank you very, very much, Dan, and to everyone involved in this, a real privilege to be with you this evening. To Professor Risch, thank you very, very much for a very eloquent discussion, very thought-provoking, and I think something that brings to the fore elements that in medicine we all tend to review and go back and introspect to see, whether observation really truly extrapolates to actual clinical benefit, whether there is true science behind it. I think most of us try and practice proper evidence-based medicine. Sometimes that's not pragmatic in a world where things are continuously evolving. I can share initially, before perhaps we engage a little, our own practice, and I think I speak for a large group of the academics in this country. And having said what you did and listened very, very carefully to your eloquent discussion, we in South Africa have had the benefit of several months of preparation and review prior to us dealing with the cases. So we had experience from China, we had experience from the USA, and experience from Europe that we could draw on. And I think many of us spent an enormous amount of time looking into therapeutic principles and what may be of benefit. And we certainly advocated chloroquine or hydroxychloroquine right at the outset. And really, certainly in the hospitalized patient, found that it probably made very little difference. We used it in conjunction with zinc. We also used a combination of vitamin C and thiamine as well. We still continue those, but we've dropped the chloroquine, both not just in very acutely ill patients, even in ambulant patients, and in the early days, patients who may possibly have been managed at home, who were kept under supervision in a hospital setting, because we in fact were all learning. And much of that, in fact, had to do with data that was published. There were some studies, largely initially observational or retrospective data collections that suggested there may be some benefit. And there were mixed messages because there were others that suggested there was no benefit at all. And then the recovery study came out looking at 11,000 patients, so not a small cohort, across a spectrum, high and low risk, from the UK. And in fact, that demonstrated possible deleterious effects, but also no potential benefit. I think many of us in this country have followed and reviewed and engaged, and I certainly did in the early days, things that were happening in the US, Dr. Zelenko's data, which looked very, very promising. And I think we're all pretty familiar with his paper, but it's 141 patients. It's a retrospective case-matched review. Yes, there were distinguishing features with high and lower risk patients, and those who were in the high risk did appear to benefit, but it is not very good evidence-based data. It's purely observational data. The FDA, as you would be familiar with, initially, in fact, allowed emergency usage of chloroquine, and they subsequently withdrew that. So emergency usage was allowed in March, in probably the earlier days. They gave authorization for that. Subsequently, they actually withdrew that based on some of these sentiments that I've expressed. And in June, in fact, withdrew totally because of the concerns. And I would imagine a lot of introspection went into making those sort of decisions. In France, exactly the same thing happened. So France initially also provided emergency use, and in fact, they've subsequently withdrawn it as well. And then we've had the publications again, and I do recognize largely in hospitalized patients, but in the mild to moderate group from Brazil, randomized study, which showed absolutely no benefit and an increased risk of potential adverse effects. So that is the evidence that's out there. There's very little in terms of early treatment. There are over 200 trials that have gone on. As you are aware, the WHO have also dropped one of the arms of really ambulatory therapy, chloroquine, and that has been dropped from the Solidarity study now based on the information available. So I think that one needs to have a pragmatic view of what there is available to us. Observational data is sometimes relevant, but we like to have firm scientific data to work on. And we do know there are anti-inflammatory effects, there are antiviral effects. That is unquestionable. Whether that truly extrapolates from the in vitro into in vivo activity, is questionable. Whether we add, as you eloquently mentioned, the companion medications, and we know that if chloroquine works as an ionophore for zinc, and we know that zinc has very excellent antiviral activity. That's been well demonstrated for decades now. And so what chloroquine allows is for zinc to penetrate cells and, in fact, as a consequence, infer its antiviral effects. And theoretically, that may, in fact, curtail the advancement of the virus and the host defense response to the virus. And given early on, that may potentially have some benefit. We did that, we've not really seen, and once again, we haven't done randomized clinical studies, but our pure observations have not matched those that have occurred elsewhere. And so the vast bulk of our patients, in fact, don't get chloroquine. I think there are many other aspects that need to be considered when we do review evidence and data. In South Africa, chloroquine sulfate is available. Elsewhere, it's chloroquine phosphate. There's also a third form of chloroquine available, or hydroxychloroquine. And so these may not all be the same. Doses vary. In fact, in China, they were using 600 milligrams BD. In Italy, they used, for durations, big doses like that for 21 days. And others loaded up front. These are very different doses to those extrapolated from the rheumatological literature. If we're treating someone with rheumatoid arthritis, they in general never get more than 200 milligrams per day. And we're not sure whether the base elements, in other words, the sulfate or the phosphate, make a difference at all. It's also well known that chloroquine, in fact, has a very long half-life. That varies, and in some texts, that may be as long as 1 month in terms of the tissue levels that are achieved. So one has to compare apples with apples, and I think that's very, very important. The side effect issues that were alluded to, the arrhythmias, particularly in older patients, and particularly in combination with azithromycin, it's really the prolongation of the QT interval. People are hypokalemic, if they're hypomagnesemic, if they're hypocalcemic, certainly could put people at risk for arrhythmias. And we have almost certainly in our own personal experience had, I can think of at least one patient who succumbed sadly as a consequence of a prolonged QT interval where there were normalized electrolytes, but who was on chloroquine and unfortunately was not able to be adequately resuscitated. So these are just some of the issues that have been bandied about, and perhaps you would like to comment on some. And then I do have a couple of additional questions that may be useful for a broader audience in terms of prophylaxis. You know, when is the most optimal time to treat? If you are advocating, at what dose are you actually advocating? What duration do you suggest? If you're advocating it should be used with zinc plus minus azithromycin, what doses would be advocated? What is suitable? And the honest answer is there's no evidence out there. So, you know, these are just pragmatic issues for discussion. There's no criticism, there are no issues, because if we all knew the answers, it would be easy. We don't. And we're all seeking to find therapies and introduce them that will make a difference. It does make sense that if you can curtail the viral aspect early on, we will limit the host defense response and the inflammation. But there may be better antivirals, potentially less toxic. Doses haven't really been adequately addressed. So, you know, I think as a group, we would really value your insights and expertise in terms of sharing your thoughts on some of those aspects.
Thanks, Prof. That's very insightful. I'm not going to come in here much other than maybe to hand back to Prof. Risch and ask Prof. Risch if he wants to maybe address some of those points.
So I agree with Dr. Mer that these are the kinds of observations one makes when you see hospitalized patients. And this is why I've been very precise with my language, that and my terms, because you have to be very clear about which disease you're treating. If you're treating ARDS in severely ill, florid pneumonia hospitalized patients, you have a totally different set of conditions and a different disease and a different responsiveness. And if you're treating well, virtually well, low risk or high risk, but early on patients outside the hospital, you have a different disease that you're treating. And you're looking to suppress viral replication rather than the immune overreaction of the ARDS. Now, I'll say a few things about that. First, that the recovery study used enormous doses of hydroxychloroquine, which were totally unwarranted. Hydroxychloroquine is an interesting drug because its dosing matters and for antiviral effects. That in large doses of hydroxychloroquine, it tends to numb the immune system. It tends to suppress adequate immune function. And there's evidence that in the doses that the recovery trial used, that's actually the effect that it gained. Whereas in the doses that are given to rheumatoid arthritis patients at 200 milligrams a day, those are the doses that are likely to be what I will refer loosely as antiviral. And so those doses are what we're talking about, and not the high doses, and not the doses in Brazil where they overdosed with chloroquine at such a high dose that it was toxic and fatal, and so on. We're not talking about that kind of dosing. We're talking about antiviral level dosing on the order of 200 milligrams BID for 5 to 7 days in conjunction with the other medications. Inpatient trials just do not deal with the question of outpatient exposures. And so for those reasons, I don't talk about any of the inpatient studies. There have been probably 8, 10 inpatient studies at least of substantial size, 4 of which I know that were published recently that gave hydroxychloroquine to patients on the first 24 to 36 hours of hospitalization, and all showed significant, substantial benefit in mortality outcomes. However, to me, that's still irrelevant because I'm talking about outpatient disease. Now, you have to be careful about thinking about early disease versus outpatient disease. You can have early disease in the hospital, but there's a reason why people are in the hospital. And at least outside in Western countries in the United States, people are in the hospital because their treatment is not manageable as outpatients. They usually have shortness of breath, which is viewed to be a critical condition and needs management and support in hospital. So we're talking about the disease within the first 5 days of symptoms. And that's not hospitalizable for almost everybody. The second point I would raise is QT interval prolongation. There's no question that numbers of drugs do this. Azithromycin does it, hydroxychloroquine does it, various other drugs do this. The question is, what does this mean? This is a physiological response to taking these medications. And the cardiologists have shown that this very prolonged QT corrected QT interval prolonged values greater than 500 milliseconds typically is an increased risk of torsades de pointes ventricular arrhythmias. And they are basically saying that it conveys a relative risk of 10 or 20-fold for those arrhythmias. If you do an observational study, that's a big deal. If I did a case control study where I found a 10-fold or 20-fold increased risk, that would be in the New England Journal of Medicine or in my epidemiology journals. That's a big deal. The problem is that if you do that with an outcome that's intrinsically rare, extremely rare to start with, the fact that you raise that rare risk 10-fold or 20-fold doesn't make it common. It's still a rare event. So these ventricular arrhythmias that do get their risks raised by a factor of 10, say, or 15 or 20, are still rare in healthy outpatient treatment of people who have basically normal electrolytes. The electrolyte problem is a problem. There are other contraindications of people who take certain medications. This is a clinical management issue. We're not saying to put hydroxychloroquine in the drinking water. What we're saying is that doctors need to manage this, and they need to be free to be able to manage this to use their clinical expertise to look at potential contraindications. If a person has cardiac arrhythmia history, that may be a contraindication not to use the combined medications, or maybe not to use hydroxychloroquine at all. But it's a medical decision that needs to be made and freely made. And that's what I'm advocating, not just willy-nilly to give it to patients. So that's the other thing, that you have to take the evidence very carefully and look at who are the patients that are being treated and what the studies for those very patients show. Now, as to the question of randomized controlled trials, there are two issues for this. One is, do randomized controlled trials have a place in emergency circumstances? The answer to that is no, given the astronomical mortality that's being faced in Western countries now, that randomized controlled trials should be carried out. But because they take months and months to do well and large enough, you cannot wait while hundreds of thousands of people are dying and you're not doing anything about it. So you use your best evidence and you evolve that best evidence as you can. You start with the best evidence. When the best evidence changes the next month, you evolve what you do. And you do that until you've reached an equilibrium that the best evidence you have is converged to tell you how to manage these patients. That's an evolutionary process that allows you to do the best for your patients. Randomized controlled trials have a place in that. Are they a gold standard? This is a question that has been addressed for quite a long time. If you read the New England Journal in 2017, the Dr. Thomas Frieden, who was head of the Centers for Disease Control, wrote a long, extended analysis of the evidence in randomized controlled trials versus the evidence in non-randomized trials and in other forms of what Dr. Merrick called observational evidence. Observational evidence is not a euphemism for junk science. Observational evidence is important and bears on the questions of drug efficacy and harm and everything else. All of these other kinds of studies are routinely used by governments day in, day out to make policies about benefits and harms of substances and medications in regulatory decisions worldwide constantly. They do not rely only on randomized controlled trials. Randomized trials have flaws in the real world. The first major flaw that is not recognized is almost none of them are big enough. Randomization helps, but randomization is not proof of lack of bias between control arms and treatment arms unless the randomized groups are huge. If you have a few hundred in each arm, the residual confounding by unmatched covariates in those arms can be significant, even though it's not statistically significant because of the randomization, but the imbalances can still be large. So randomization needs to be huge, and studies are not designed by the size of the residual confounding, but by the size of the effect that's planned to be measured. So already most studies are too small. And certainly all of the studies that have been done in outpatients, all the Boulware and Mijah studies that have been out so far have been too small. Why they've been stopped is another question to address. In any event, randomized trials in the real world have flaws. They are evidence. They can be very good evidence when they're done well, but so far they haven't been done well for various reasons. And that's why it requires all of the evidence to be done, to be evaluated in the context of what are the circumstances and who are the people who are being treated. And that's all that I'm saying is look at the evidence for the people you need to treat.
Thanks. Thank you very much for those very valid comments. And I think everyone would recognize that in the midst of a pandemic, it's sometimes incredibly difficult to actually go and do randomized clinical studies, and that observational data does potentially have a role, particularly if there are potential benefits. I think if we really have to take a balanced view, and I think that's what we as clinicians, scientists ought to be doing, such that we can confer the best benefit to patients and limit potentially adverse outcomes, albeit that our intention across the board is always to guide and confer the best therapies that we can. I think we have to acknowledge that there's no clear evidence at all in terms of the early intervention and treatment. The jury is still very much out there at this point in time. I think the dose, as you very much alluded to, has been so variable that no one actually knows what the correct dose is. And in fact, 400 milligrams, which was the dose that we initially actually were using, 200 BD, we did give a load on day one. We never used it for more than 5 days. And we utilized that in ambulatory patients, but we're not seeing the same benefits, even when used in combination with zinc, albeit I will absolutely acknowledge that there are certainly theoretical advantages to doing that. What we really do require in this disease, and one commends you for the insights and for sharing and for pushing issues, is that we definitely need something that can in fact halt the progression early on to potentially more deleterious and severe disease and potentially fatal outcomes. You're entirely correct. Down the line, there's no benefit whatsoever. Are there better drugs? There may well be. There may well be, and that's what really needs to be put out there. But I think realistically, the jury is still out. I think most people would concur with that. I think it's commendable to be out there pointing out elements, because there must always be two sides to every coin. And unless one sees two sides, you can never, in fact, get a balanced viewpoint. But at this point in time, certainly in our practice, based on what we currently do understand, inclusive of the observational data, inclusive of the theoretical potential benefits, certainly we are not advocating, and I think many practitioners within the context of South Africa, and we're talking about the very entity that you're alluding to, either very mild disease or patients who in our context may be treated in your context, in the home scenario. Sometimes those are treated in a care facility in our context because of logistics and people not being able to get back to hospital should they deteriorate. We have not seen those benefits conferred. So, ultimately, the only way we really are going to know is if there is some evidence that does come through. And as you correctly say, big numbers will be required to actually demonstrate that. The potential and the theory about having antiviral activity as well as anti-inflammatory activity, that there's no debate about. We do need to have a look as to whether the different chloroquine salts make a difference, and whether those confer benefit differentially. And I think as well, we need to look at the combination drugs. But I think in many areas of the world, we are seeing much of this pandemic, I'd like to believe, behind us, although it's not over by any stretch. And so we may never, in fact, get that information in proper studies. And I think the jury may still remain hung on what is good and what isn't. Ultimately, it'll boil down to what we believe may be in our patients' best interests, without, in fact, subjecting them to any harm. Whilst we're on this debate, and I think a couple of other issues, and so I think we should probably, in terms of from a therapeutic perspective, have the insights from both sides. As I said, the jury is out, and I think we have to recognize that. But perhaps you would like to comment on things like the use of chloroquine or hydroxychloroquine for prophylaxis, for post-exposure prophylaxis, and what your thoughts are on there, because there was a lot of enthusiasm, and that enthusiasm has also waned. We alluded to the big study in the UK earlier on. There's a study that's taking place across a variety of continents, driven by the MORU group, the Myodol Oxford Research Trials group, and they have 40,000 people across a variety of continents, the Americas, South America, and North America, Europe, Asia, and Africa as well, looking at this very issue of prophylaxis. Perhaps your thoughts on this. The early data, again, hasn't been impressive, but I think we would, as a group, appreciate your thoughts on these aspects.
Thank you. Yes. So I haven't actually described any of the evidence, excuse me, that I've reviewed, which I'm happy to do. I'll start with prophylaxis, which I think is actually a weaker case to make from the evidence. Also, I think that saying post-exposure prophylaxis is not actually prophylaxis, it's treatment, it's early treatment. So I've seen published 3 studies out of India treating healthcare workers prophylactically. All 3 show reduced risk of infection after a degree of dosage has been accomplished. Generally, 3 to 4 weekly doses of hydroxychloroquine shows then reduced risk of gaining the infection. All 3 studies show that. There's another study that was done in Vadodara in western province of Gujarat in India, where they gave the city 342,000 doses. They gave 342,000 people hydroxychloroquine. This is just by itself, no companion medications. Then they went and sampled 100,000 people in the city to see how many got COVID infections and how they did. And what they found is that people who had taken more doses of hydroxychloroquine, it was a weekly thing, and they sampled them during the process. People who had taken more doses had a lower risk of getting the infection, a significantly lower risk. Dose response trend in that. Furthermore, among the people who had had more doses, the mortality risks were lower depending upon the number of doses, so that the deaths, while they weren't large, were still significantly reduced by a factor of 3 with each successive dose. So that for having taken 2 doses in total, the risk was cut in a third of mortality among the people who got the illness. And for taking 3 doses, it was cut to a 10th. So that's dose response evidence in just that usage. Now, there's a study in Portugal that what the Portuguese investigators did is they linked the database for everybody who had been diagnosed with COVID, which they maintain as a national registry, to people who've been using hydroxychloroquine in rheumatoid arthritis and other conditions. And what they showed is that people who have been taking the RA doses, 200 milligrams a day typically, for rheumatoid arthritis and so on, had half the risk of becoming infected with COVID as people who weren't taking it, age adjusted and so on. So there's evidence also for prophylaxis. These are observational studies. They're not strong, I grant you that, but that's the evidence that we have for now. Now, as to the evidence for usage of these medications in early treatment, there's a number of studies that provide very strong evidence. The first class of studies are actual trials that use the medications in patients that were not randomized trials, but they're controlled trials. 2 of these trials have been done in Brazil in different groups. The first one was in the Prevent Senior HMO. Sorry, I'm losing my voice here. The Prevent Senior HMO that investigated individuals who had used hydroxychloroquine and found that people who had used it, so this was a telemedicine study where sequential patients were offered hydroxychloroquine and could either choose to take it or not. And the patients themselves chose, and generally the ones who were sicker, who were more symptomatic, were more likely to take the medication. Ones who were less ill felt that maybe they could get along without it, and so they didn't take it. And what they found was that hospitalization risk was 4-fold higher among the people who did not take hydroxychloroquine, statistically significantly so, compared to the people who did take it. And the risk of hospitalization was lower among the people who took it early versus the people who took it late. Now, you'd say, well, this is an observational study. It was a sequential patient study. So the only question is, what's different between the people who chose to take it and the people who chose not to take it? And the answer to that was given by the authors in a table of comorbidities and degrees of illness, indicators of illness of those patients. And it's very clear that the patients who took the medication were sicker, slightly sicker, and had more comorbidities than the patients who didn't take it. Nevertheless, even with that disadvantage to the medicine efficacy, the medicine still shows that those patients who took it who were sicker did better. That's the first study, first trial. The second trial is another trial in Brazil that has not been published. It's submitted for publication. It was done by Brazilian co-authors in an HMO with 6 million members across the country. They graciously allowed me to participate in that study, and so I'm aware of the analyses and the write-up of the study, and it's under submission, so I have the data and I can speak to it in a general way as to what it found. This study involved 717 sequential patients, all tested positive by PCR for SARS-CoV-2, who were started on a new trial starting at the beginning of May, where the clinicians in this HMO were offered the opportunity to use any of 6 different medications for treating their patients on their own clinical judgment: hydroxychloroquine, azithromycin, ivermectin, prednisone starting on day 6 of symptoms, oseltamivir, another 1 or 2 medications that weren't used very frequently. And so in this study, what they found was that patients who got hydroxychloroquine by itself, in other words, could have been with other medications, but not with prednisone, had a 50% lower risk of hospitalization. Patients who got prednisone starting on symptoms day 6 had a 50% lowered risk of hospitalization. Patients who got both together, hydroxychloroquine and prednisone on day 6, had a 60% lower risk of hospitalization. All of these 3 were statistically significant. On top of that, patients who got azithromycin, in addition to the others, had a 15% lower risk of hospitalization compared to the others, not statistically significant. Patients who got ivermectin did not show a benefit for hospitalization when adjusted for these other medications. This analysis was adjusted for obesity, diabetes, cardiovascular disease, gender, age, and so on. The patients who got hydroxychloroquine and prednisone tended to be slightly sicker, again, and because the clinicians made the decisions that these people needed the medications more. This was, again, an outpatient study where the patients presented to the clinics of this HMO all across the country, and again shows very statistically significant benefit when adjusted for comorbidities and degree of illness. That's the second study. The third study is one done by the Marseille group. Now, it's not the one that the notorious study done at the very beginning. This is the study that was done later by the Marseille group after they had collected some 3,700 patients. In that group, so there's a lot to criticize in that study, and I don't want to go into the details because the criticism is valid. But within that study collected approximately, I think, 199 patients who had received hydroxychloroquine plus azithromycin at least 5 days of usage. And what they did is they matched those patients to 199 other patients, matched on degrees of comorbidities and degrees of illness progression in patients over age 60, all over age 60, and looked at mortality as the outcome. And in that stratified matched analysis, what they found is that the medication cut the risk of mortality more than in half, by 60%. In this analysis, these patients were all over age 60, and they were adjusted, they were matched on comorbidities and degree of illness. So there's very little room to criticize that on the basis of those possible confounders. So that's another data point on this analysis. I've already spoken about the Portugal study. Then we come to the case report series in US doctors. Now, in general, when one reads a case report in the medical literature, the question is what kind of evidence that provides. And as an epidemiologist, I say, what is that generalizing to? Is it generalizing to all patients? Is it generalizing to all exposures? And so on. On single patients, obviously, you don't have that generalizability. But in a series of cases, the question of generalizability is a valid question. When I do a case control study, when epidemiologists do case control studies, the point is to collect a representative series of cases of a disease so that one can generalize to the disease as a whole. And so when a doctor collects information about a series of patients, 50 or 100 or 800 patients, those patients, if representing a sequential series of patients as seen by that doctor, represent the collected experience of cases that occur that are treated by that physician. Okay, so there is a degree of generalizability in that. Secondly, what we have now is 5 or 6 physicians who've reported in the literature, on the media, or to me, saying that they've treated their sequential patients with hydroxychloroquine and companion medications, generally with azithromycin and zinc, okay, and had vanishingly small mortality, hospitalizations or mortality. These doctors have had between 50 and 100 patients that they've treated this way, or perhaps Dr. Zelenko with his 800 patients. Now, the counter argument to this is, well, maybe these people emailed you to tell you they had such great responses precisely because they're the ones who got these great results, and all the people across the country who didn't succeed, they didn't tell you it because they didn't succeed. So I'll say, okay, I'll entertain that as a hypothesis. And so then one says, okay, well, Dr. Zelenko told me, or I found out about his results when he had treated 400 high-risk outpatients and had 2 deaths. And then Dr. Proctor in Texas emailed me when he had seen 50 patients, all high-risk patients, and no deaths. So, okay, I said, well, why don't you go back? This was now in May. Why don't you go back and prove to me that what you do works? So now instead of surveying doctors across the country, I'm saying, I pick these 2 doctors. They say that it works. Go forward, treat more patients, more high-risk patients, and see whether it works. Prove to me that what you do works. And what they did is they spent more time and collected more patients. Dr. Proctor treated an additional 50 patients in the same way, 0 deaths. Dr. Zelenko treated an additional 400 high-risk patients in the same way, 0 deaths. So now what we have is an a priori hypothesis about 450 sequentially treated patients, high-risk patients, treated the same way with no deaths. So now the question is, what underlying probability of mortality should there be for high-risk patients who, if they hadn't been treated, would have died? Well, we know that the risk of mortality in untreated high-risk patients is in the order of 10 to 15%. In Connecticut, it's over 20%. But let's say I grant you 10% or 5% or 2%, even 2% for untreated mortality in high-risk patients. The probability of seeing 450 people and no deaths with such even that low of an underlying probability is 0, is essentially 0. The p-value for that is 0. If the p-value for seeing 450 patients with a baseline risk of 1% is 0.01. You take 1 minus 0.01, the 1 minus the 1%, raise that to the 450 power, you get 0.01. So 1 minus 0.02, 1 minus 2% is already vanishingly small. The probability that they could have seen that as an a priori hypothesis for treating those patients is 0. It is essentially proof that what they did.
Sorry, go ahead.
So
I'm going to ask. The evidence is overwhelmingly interesting.
Yes.
Here. I'm going to ask you just for time if we can, because I want to move on to the next part, and then we'll leave questions on the evidence for, beyond this. So I'm going to just spotlight you again. And
okay, so I'll just finish to say that this is proof that whatever these 2 doctors are doing works. The question is, how would you generalize that to all treatments across the country of the same kinds of people, of the generalizable high-risk outpatient people? That's the only question to be addressed.
Okay, thank you very much. I think we needed to hear the trail of evidence there, and how you come into these decisions, and also what the lack of seemingly lack of harm that there is of the interventions in these groups. So, but I'm gonna slip into a different gear completely. Just like when the teacher at school says, everybody stand up and, you know, shake your legs and wake up. It's late here in South Africa at night. Firstly, I just want to thank a couple of people. I want to thank Dan Stillerman. He's the non-doctor on the group here tonight. He's often been, he's waving, if you can see him on the camera. He's come into all the sessions so far, for some or all of the time. He does a lot of Zoom work in the community by and large, and he really has helped us ongoingly. He's got a company called the Excel Academy, where he teaches people how or organizations how to use Excel. He's now become the Zoom and webinar fundi, and he's a wonderful guy to work with. And again, we're all very appreciative for his ongoing support and help. I've got to, in the same stream, thank my wife, who's actually not here at my practice, because she is at my house using the other bandwidth, where she is also spotlighting. So when Dan goes off now, she just carries on doing the spotlighting. So she also does it on the meeting. So thank you to her. And I've got to thank Paul Frankel, one of our doctors, who reached out to Prof. Risch and got him involved. So these are, and has really been engaging with him, and has been the driver behind the whole debate to the chloroquine on our group. So thank you to all of you. And that's besides the panelists who have been so wonderful tonight. And we're still going to get to Dr. Levy and come back to Prof. Karim for some questions, and for others for some questions. So just thank you for that. So if I could go to Dr. Brian Levy. Dr. Brian Levy is a specialist, as I said, at Netcare Rosebank Clinic. He was from Wits. He's an intensivist, anesthetist, intensivist. On all these panels, we get a clinician who's very actively involved on the coalface in terms of, in the private sector as well, treating COVID patients. We as GPs, or as primary care physicians, and for those of us who aren't GPs on the panel here tonight, still are very involved. In fact, say there's a guy on here tonight who's still giving patients advice in terms of what they must and mustn't do as an outpatient in terms of COVID management. We are guided by the experts in the hospitals who are seeing COVID a bit further down the line, and who have insights as to when to oxygenate, how to oxygenate, what works, what doesn't. So if I could hand over to Brian and ask Brian to just give us a little bit of insight as our resident clinician at night, is what you're seeing, what comorbidities are making a big difference, what you're advising to doctors on the ground at this time, and just any other insights that you're seeing in between the discussion here tonight that you'd like to put across. And then we'll do a brief Q&A, and we'll try and finish off, around the top of an hour or so. So over to Brian.
Thanks very much. Thanks very much, Dan. Good evening, everybody. Just wanted to say thanks to Prof. Risch, as well as Prof. Karim and Prof. Mer. Your insights and expertise is always valuable. Thank you. So really, it's been very interesting because we've been watching, the European data and the American data, and even the Western Cape. And we all predicted a sort of a 6-week peak, and we were quite surprised, maybe a little bit disappointed at times, but largely quite happy that the peak in Gauteng lasted for about 2 weeks, and it was quite puzzling. So it was good to hear the insights of Prof. Karim on that. Certainly in terms of comorbidity and severity of disease. This has definitely been an unprecedented disease that we're really not familiar with at all. It hasn't followed any of the usual patterns in terms of severe sepsis, etc. And it would seem that the biggest morbidity is severe obesity. And I think that's the one take-home message, perhaps in your practices. I think the disease could potentially be beaten before the hospital setting. The biggest risk that we noticed is severe obesity. We're getting patients that were 150 kilograms and could barely breathe. And I think those are the high-risk groups. The uncontrolled hypertensives and the diabetes, definitely, certainly diabetes is a problem. And then as well as age. But to be honest, we've had some octogenarians, nanogerians who've actually done pretty well and surprised all of us. Yeah, I think that's about it, really. At the moment, it's quiet. So yeah, we'll have to wait and see.
Okay, great. So Brian, what I'm going to do is I'm going to leave it for the Q&A, because I know that in the Q&A we always get a lot of clinical stuff, and I think that with our panel here, it will be very helpful to try and let you answer some stuff in the Q&A. Okay, so once again for the Q&A, we're going to encourage anyone who wants to talk. Please just write that you want to talk and maybe raise your hand, because I can see on the list of participants here, if a hand is raised, I can see that you're happy to talk. I'll just try and go through it and see if we, so I see Ravashni wrote here, Ravashni Sukai wrote, she said that, I'll just read it out. It's a clinical management question, so we'll pose it to Brian, to Dr. Levy. It says, in GP management, the majority of cases are mild, but a lot of patients complain of shortness of breath, especially at night. So we know that oral and injectable steroids should be avoided in the mild disease, which we've discussed before. So she's talking about in the viremic stage, in early COVID-19. But what are other options to help patients who can't breathe besides oxygen? I assume she's talking about Montelukast. Can we use inhaled steroids? What are the current thoughts? Even inhalers like Symbicort. And then she speaks a bit about vitamins, which maybe we'll leave as another question. But can you just talk about, Brian, maybe about airway, helping patients in terms of outpatient airway help, in terms of inhaled corticosteroids, etc.
Okay, thanks, Dan. So as we think we understand, the disease is basically an inflammatory disease. And it has two main components. So the one would be the sort of inflammatory component within the lung. The second would be a thrombotic or coagulopathy component. So I think as patients start to become symptomatic, and specifically with respiratory symptoms, one has to be concerned that you are moving into the coagulopathy phase, and potentially as well as into the lung COVID ARDS phase, or whatever you want to call it. The current sort of thinking, as alluded to in the question, is that steroids should be reserved for those patients where the SATs are potentially down, and if you're at sea level, I think they're taking the cutoff at about 94%. In room air, in Johannesburg or at altitude, we're taking it at about 92%. But there is some thought that if you had to check a CRP, and if the CRP were up, then to consider taking oral steroids. I suspect the same would be true for inhaled steroids. And if Prof. Mer's around, I think he would be able to answer that question better than I can. The second thing is then to also consider the coagulopathy. And there it may also be worth checking a D-dimer. And if that is elevated, then to consider anticoagulation, which I suspect has been spoken about at last week's meeting. And they're looking at things like Xarelto, perhaps a low-dose aspirin, and that may offset the progression of the disease. Certainly vitamin C seems to be of benefit, zinc as well, perhaps in combination with vitamin D, because that may help the zinc absorption. And certainly with those agents or those medications, if you like, their side effect profile is minimal, so potentially worth trying that. The chloroquine, we've had a big debate about that, and I agree to an extent with Prof. Risch that the studies that are out there have not been that amazing. and mixing a bag of Smarties and trying to, decide which ones are green and blues is often difficult. So chloroquine potentially. Regarding the respiratory symptoms, so what has been found to be of quite significant benefit is to encourage the patients to prone themselves. So if they are symptomatic and they're at home, then try to let them sleep on their stomachs. That certainly helps with the VQ mismatch. The patients often feel a lot better with that. It has to be done properly so that the abdomen is free, so that the diaphragm can move freely, and that often helps with the symptomatology there. I think if the saturations continue to drop, then early admission to hospital for intravenous steroids and full anticoagulation would be of benefit. But I think the key there again is early therapy.
Okay, great.
I just want to support that there's been a number of individuals in the US who've been using inhaled budesonide early on and have had also very, very successful results with that. The other thing is people have started thinking that vitamin C might be harmful in the inflammatory phase. Once you get to shortness of breath, at that point, that the vitamin C may actually counteract and cause increased inflammation rather than interfere with the inflammatory process. So it may be beneficial early, but not so later. And vitamin D seems to be better all along, all through the whole process.
Yeah, there's also been some research looking at bisulfan, and that may have something. And that may have some beneficial effect as well.
Okay, great. What I'm going to do at this point, just very briefly, in terms of continuity from our previous webinar, because Dr. Levy touched on the story with the Xarelto, Clexane, etc., is I'm going to cross very briefly to Prof. Jacobson, who's on the panel, who will just tell us, he had spoken about a study that they're doing that he's invited GPs to be a part of, and I think doctors as a whole. And just very briefly, I've asked him to just make it quick so we can carry on with other Q&As. Just tell us about what's happening with that and how we can be a part of that. So go ahead, Prof. Jacobson. You're on mute. Okay.
Okay, I'm unmuted. Thanks very much, Daniel, for giving me the opportunity, and to thank you to all the speakers. I must, before I continue, say I agree with Mervyn. Harry Bueller says, in God we trust, everyone shows the evidence. So we actually going to be starting now a randomized trial, which is powered to show a difference in using Clexane on patients at home. I think Clexane has shown in other words, low molecular heparins have shown to have antiviral activity. And we're going to be using Clexane for patients on home treatment. So patients that are going home, and the patients are over 50, and then they either have to have comorbid disease, either have COPD or be greater than 70, or have underlying cardiovascular disease. So the high-risk patients at home will be randomized to Clexane or nothing. It'll be, if they're under 100 kilos, it'll be 40 milligrams. If they're over 100 kilos, they'll be getting 40 milligrams twice a day. We want the GPs to participate. You can all get my number. I'm on the internet, or you can speak to Daniel. But we're going to put it out for you now. But my cell number is, contact me on my cell. But we want patients to participate for your patients that are going home, and then we're going to be randomized them. So I really think that Clexane will be given for the patients for up to 3 weeks, and it'll be provided free of charge. And the rest of the treatment we will be monitoring them. We'll be doing video consults with these patients. So we look forward to everyone joining in with them. Thank you very much, Dan. We'll back very short. Thank you for allowing me to promulgate our study.
Okay, great. If I could ask you, Prof, if you don't mind, just writing on the Q&A, just some contact detail.
Sure.
whether it's a cell number or an email address so people can get hold of you. If I could ask a question to Prof. Karim, and I've seen this, I mean, this question's actually come through on the pre-webinar WhatsApp group and a few times on the chat here. Sorry, that's just my power saving lights going off there. So if I could ask Prof. Karim, there's been a lot of questions from patients and from doctors as to whether the seasonal change in South Africa, and we saw this in the, I don't know if he's actually here anymore. Is Prof. Karim still on the webinar? Let's just see. He might no longer be on. Okay, great. So we'll ask one of the other experts here. I think you have to go. Whether in light of the evidence that sunlight, you know, he spoke about how sunlight, there was a study that it destroys COVID. Will the warm weather bring a decrease in COVID? We've seen second waves in the Northern Hemisphere, certainly America at the moment. Will the warm weather make a difference? I mean, maybe we should start with Prof. Risch, just in terms of him being in that place, or anyone else who wants to comment. Prof. Mervyn, Dr. Levy.
So I think our second wave occurred because of the relaxation of all of our stay-at-home orders, and people were generally mixing and so on. I think this is also something that was seen dramatically in Israel, where they basically opened up their society 2 weeks too soon and created a second wave that's bigger than the first wave. I think it's hard to know about the seasonality of this. There's some evidence, but probably it's not such a big deal. I think that early on, we didn't see infection differences in Australia, for example, compared to the United States, which was seasonally somewhat different. And it's really hard to know exactly how strong a seasonal effect there is. The main seasonal effect is on influenza, which dropped more or less out of sight by the end of March. It's down to maybe 5% of respiratory infections in the US now, as opposed to being the majority 2 months before that. And how this is going to play out coming into the new influenza season will just make it more difficult to actually be sure that one is treating COVID as opposed to influenza. Now it's pretty clear if somebody is symptomatic with any of the flu-like symptoms, 2 or more of those, or shortness of breath, that you're dealing clinically with the case, and the testing is confirmatory, not diagnostic, because you need to treat them as soon as possible for the high-risk people. So I don't think we're going to have a good handle on seasonality until we've been through maybe a full year or have been able to extrapolate from you guys in the Southern Hemisphere to try to figure out what the behavior is. And it's really hard to do that in the face of stay-at-home orders that come and go and interfere with just the average behavior of the pandemic itself.
Okay. Thank you. Can I ask Prof. Mer if you'd like to comment on that? And at the same time, I see there's a question asking about inhaled heparin. Yeah, I mean, would you like to comment on that? If there's any usage of inhaled heparin at Joburg Gen, and any thoughts on that?
Yes, thanks very much, Dan. I'll deal with the latter one initially. There is data that heparin has both anti-inflammatory and antiviral activity. And in fact, there's a paper recently out suggesting it may be of benefit. We haven't used it. So that answers, hopefully, that question. It's, again, a theoretical benefit. And in fact, some years ago, we, in fact, wrote a paper published in the SAMJ showing that inhaled heparin had benefits for uncontrolled asthmatics. So there's no question about its anti-inflammatory activity. It also has antiviral activity as well, but it is not universally used. It is a theoretical potential, but there is one paper that's actually out. And in terms of the seasonality, Prof. Risch has already alluded to the elements in Israel, where the weather currently is warm, and in fact, they've had a second surge And so the weather issues may not be as big an issue as previously thought. Rather the other elements, the social distancing, opening up too early, and in fact, a discussion at a provincial level took place with respect to that earlier today, determining, what we in fact should be doing in this province with respect to it, and we won't be in a hurry to just limit things, and until such time as we're comfortable that people will still adhere, and with whether that may potentially be improving and numbers that are going down, and the Israeli experience was in fact shared today. So I agree entirely with Prof. Risch on that entity. Just a very brief comment on the inhaled budesonide. There is good data, again observational, that suggests it may be of benefit, as alluded to by Prof. Risch, and maybe even better siclesonide, which may in fact have some antiviral activity as well. And remember, siclesonide is only activated in the respiratory epithelium, so there is no systemic absorptions, 1%, the bioavailability. So an added issue there. Whether leukotriene antagonists, and I know those were some of the unanswered questions earlier, make any difference, there's very little evidence to support that at all at this point, but it does address an aspect of the pathway that steroids do not address. But no evidence at all to suggest that it should be used.
Okay, and while we have you, maybe we can just talk about this issue continually comes up in our group about non-steroidals, because we know that initially non-steroidals were touted as bad, and now we are saying that perhaps, and this was a paper that came out saying that they were permissible as long as there are no other contraindications. Are you using them? Maybe Brian wants to talk about that as well, but whether they're being used. And as GPs, let's bring this back to the outpatient space. Are we able to, we often in this practice have patients who come or phone in and say, the fever is uncontrollable, I feel terrible. Is it safe to add a diclofenac or an agent like that to an outpatient who's, we think renal function is fine in the picture of COVID? Prof. Mer, and then Dr. Levy, what you guys are doing.
So in our practice, we're not using any non-steroidal anti-inflammatories. We use paracetamol if necessary. That related to the initial concerns about the use of non-steroidals. Obviously, there are many other effects. You are correct. There was a second paper recently published that suggested, in fact, the initial concerns were minimized, but our current practice is not to use non-steroidal anti-inflammatories.
Okay. Dr. Levy, do you want to tell us what you guys? I mean, we've heard previously that on this forum that it is okay. So obviously, no rights and wrongs. I don't know what's happening in your circles.
Yeah. So Dan, I agree 100% with Prof. Mer. We don't use non-steroidals anti-inflammatories at all. Again, our population, though, is already hospital based. The patients are quite sick, but I wouldn't use a non-steroidal. It just makes me nervous.
Okay, great. I'm just going through some of the Q&A on the right. I see that there is, we've had a few questions also on the group about patients who've developed myocarditis. Obviously from a GP perspective, we sometimes have patients at home complaining about chest pain. We've had the experience of, or we've had the discussion on this group about when we should send patients for bloods. And on the previous webinars, we've had discussions about if a patient's short of breath and they're deteriorating, and certainly if they're not eating well, or they seem to, their vitals for sure, if they're sats, we would send the sister to them or send them for bloods. We have had cases where a patient feels okay, and then it emerges later on that they were okay, but they developed a myocarditis. Are there any early signs? I know we're not specifically speaking to cardiologists here, but are there any early signs as GPs that we can use to try and screen for patients at home who may be getting that complication from an outpatient setting. I know it sounds a little hard to do like remotely, but the reality is this is what we're dealing with. Patients who phone in and say they think they're okay. This is a concern we have. Any experience from anyone who wants to add to that? I can see you all, so just including you, Prof. Jacobson, just raise your hand. No?
Yeah. I think from a pragmatic perspective, one of the things we pride ourselves on as South African trained clinicians is clinical acumen. And I think that should never be forgotten. In fact, I think it's something that we don't place enough emphasis on. But what is relevant there, if you have an unexplained ongoing tachycardia, take it seriously and go back and evaluate that patient in the context in which the patient is potentially at risk. So if a patient is getting better, there should not be an ongoing unexplained tachycardia. And I think at a family practitioner, primary healthcare level, just bear that in mind. That would be the single biggest, most important issue to evaluate.
And if I can just add to that, is that patients shouldn't exercise if they are COVID positive. The risk of developing a carditis while they're COVID positive and or symptomatic and carditis is quite high.
How long should they not exercise for, Brian?
So the American Cardiology Association, in the asymptomatic patient, they say 2 weeks after being tested positive. In the symptomatic patient, they say 2 weeks after the symptoms have resolved. But if they have had any respiratory symptoms, then or cardiac symptoms, then up to 6 months. There's no exercise.
Okay. There are quite a few questions here for Prof. Karim. It's a pity that he wasn't able to stay till the end. There seem to be quite a few questions about antibody testing and testing as a whole. So the first question, and I don't know if any of us have insight to this, I mean, just being in the academic circles you are, is, why are we testing less as a whole? He spoke a lot about, it's not just about the number of cases coming down versus the number of tests, but it's actually the number of positive cases per test done. Why are we testing as a whole? We're seeing overseas, certainly the move is to try and ramp up the testing as much as possible. In South Africa, we're seeing the numbers coming down, but we're also seeing the number of tests coming down. Any insights as to why that's happening? I know nobody has in that field, so to speak. I don't know if Prof. Jacobson has any insight into this. Yeah, please. You unmute. It's unmute. Can you just unmute yourself in the?
Oh, but then you had to allow me. Someone was not allowing me. So
sorry.
Okay, so our department actually looked at the various studies of the antibodies and found that they weren't that great, to be quite honest. They varied quite to difficulty. Dr. Elizabeth Main, Professor Elizabeth Main, evaluated them. And then also the question is, what do you do with that data? Are they asymptomatic carriers? Are they going to be resistant? Are they going to get a new infection in the future? So there's been that whole question has been quite a difficult one to answer in a country with relatively limited resources. Spending your money on what should we be spending our money on? So from the state point of view, it's definitely been not that great to be doing antibody testing, in terms of what we're getting out there. Now that we're going to do more antibody testing, maybe for trials and see what goes on, is a separate issue to address. But the idea of having the antibody tests and saying whether they're immune or not immune is a very moot point at the moment. And I don't think we really know what to do with that data. I don't know if that helps.
But it is very encouraging though that there is a test that has been, the gene orient test that has been approved. So hopefully, like certainly in the private sector, that test will be able to be rolled out more, because it will be able to tell patients, okay, so speaking of which, always on every webinar, the question of immunity comes up. I don't know if we want to ask Prof. Risch, like from your readings and as an epidemiologist, can you comment on studies that you've read? Prof. Risch, Prof. Jacobson, thank you for joining us on Prof. Mer on immunity. We know that we've seen that recent studies have shown a waning immunity after 3 months or so. you know, we're being asked how long are people, what's a safe time to tell people that they are immune to COVID once having a fall at the moment?
So some really interesting data came out from Dr. Zelenko while he was doing his treatment. So he basically served a village in New York by the name of Kiryas Joel. And this village has about 28,000 residents there. It's a religious sect that largely is a bubble in society, their own small society as a whole. So he did a telephone sero survey. He basically allowed people to call in if they wanted to get their antibodies tested. And he ended up testing, I think, about 3,000 people out of this village. And what he found was approximately 30% of the people carried antibodies in his testing. Now, it's not a scientific sample because you don't really know who called, but the interesting thing is that that village has stopped producing new cases, that the epidemic has gone through it, that anecdotally people say, oh yeah, I had a flu-like illness in April and went away and I've just been living normal life. And so he has almost entirely stopped treating new patients that way because there aren't any there. And this is on the basis of antibody testing at 30%. So the question is, why are the other, is that herd immunity already? It seems to be acting like it's herd immunity. And we know that herd immunity doesn't work at 30% for a virus that has an R0 of 3 or plus or minus whatever it is. So the question really is, do people in general have some degree of immunity, maybe not perfect immunity, but some degree of resistance to acquiring the infection based on some kind of overlapping immunity to other cold viruses and so on. And that people have hypothesized that approximately half the population has some degree of resistance that either gives them the opportunity, if they get infected, not to manifest it, so they're asymptomatic and not make new antibodies, or they don't actually get it at all, that their antibodies, whatever they have, that's not measured the same way, are sufficient to keep them from getting the infection in the first place. We can't tell the difference. It's just that the antibody testing shows that that level of protection occurred. Now, the second thing about that is, it's probably not all IgG antibodies. The T cell resistance to this infection is probably playing a lot bigger role than we know about, and that's not something that we've measured very well or very much until very recently. So we have to factor that into how long the resistance to infection lasts. Now, I've heard of 2 cases of 2 individuals who are documented to have had SARS-CoV-2 infections in March, April, and then proceeded to be re-diagnosed 3 to 4 months later. So that's 2 people. It's hard to know, and I think they are having some kind of sequencing of their virus to see if it's really the same virus or not, and in other words, whether it's a manifestation of the original infection or it's a new infection. I don't know the status of that work, but 2 people out of the hundreds of thousands in the New York area seems like a pretty rare occurrence and not what you would generalize from.
Okay, thank you. I've tried to just group some, we're almost out of time, so I've just tried to group some themes of the last few questions. The one that keeps coming up is steroids. There have been quite a few questions as to, I'm going to ask this question to Dr. Levy, is when a patient goes home from hospital and they've been on steroids, on cortisone, or even when they're not, I mean, we're seeing this at home patients. We're seeing patients with protracted illness in terms of inflammation and difficulty breathing. And we've seen certainly that in those patients, certain patients who have gone into the pneumonic phase, we've seen they have corticosteroids help. How, is there a place for GPs or outpatient doctors to be treating patients with steroids? And if so, for how long? I mean, when you send your patients home, are you sending them home with a TTO of steroids, and how long are you weaning them after? And then Dr. van der Merwe had asked a question there in terms of proton pump inhibitors. Well, we can put that in as well, as how long, should we be covering patients with proton pump inhibitors, and are proton pump inhibitors safe with COVID?
Thanks, Dan. So the second question first, it regards proton pump inhibitors. We certainly use them. We actually use a double dose just because we're using quite high doses of steroids in our ICU patients. And there certainly doesn't seem to be significant deleterious effect in using the PPI. So I think that's safe to use. Regarding the steroids and the duration of steroid therapy, I think that depends largely on the symptomatology. If the patients are still symptomatic, then a low dose steroid continuing until the symptoms resolve, or it seems like the steroids are not helping, would be okay. The duration of the steroid therapy, once symptoms have resolved, I think it's more a case of just weaning the patients off their steroids at a safe rate. I don't think there's any benefit in continuing the steroids for 2 weeks or 3 weeks to avoid recurrence of symptomatology. So I think it all depends on the respiratory symptoms and if they've resolved or not.
Okay, great. So can I ask Prof. Mer, one of the last ones is, there's 2 questions or 3 in this Q&A about ivermectin, and at the end about sorry, I just want to find it here, about colchicine. Can you comment on colchicine and ivermectin as independent treatment modalities and any evidence that's come to light regarding them and practice regarding them, maybe in an outpatient setting?
So ivermectin has been, there've been a couple of papers on that. It's an antiparasitic used largely in the veterinary world. There appear to be promising papers, but doses, once again, have not been readily determined. And the honest answer is we need further evidence. We would not be advocating it at this point in time. In terms of colchicine, in fact, it's a very interesting question, because right at the outset of this particular pandemic in South Africa, we in fact started in our severely ill patients. I'll just use that and extrapolate it back to the primary healthcare practitioner. We started using colchicine based on the fact that many years ago for interstitial inflammatory lung conditions, colchicine was used as an anti-inflammatory, antifibrotic agent. It's generally well tolerated in low doses, 0.5 milligrams twice daily. And so for the patients who landed up severely ill with us on a ventilator, in fact, we're using it, and in some instances continuing beyond the time that they were liberated from the ventilator and in fact discharged to the wards and then went home. So that was our initial rationale. Subsequently, what transpired was that there was a study called the Greco study, which looked at just over 100 patients and demonstrated some impact in terms of the severity of illness that subsequently transpired. So that has some relevance for the primary healthcare practitioner. And then the third bit of work on colchicine, in fact, came from some Israeli work, where they in fact looked at a protein called alpha-defensin. And alpha-defensin is deemed to be relevant, and Prof. Jacobson may want to comment on this, in terms of the coagulation cascade. And so, again, theoretically, they extrapolated that colchicine may in fact have some benefits, not just on the progression of disease as alluded to, but may in fact inhibit some of the immunothrombosis, and I think that's the correct term to use, small and large vessel thrombosis that in fact occurs. But all of these things are in fact postulates. None of them have been definitively shown, bar the Greco study, which is just over 100 odd patients, where in fact limitation of progression to severity of disease was shown. So there may be some promising data that comes out of that.
Okay, great. We're about to close off in the next few minutes. Just while I'm just saying these last few things, if you would like to say something, please just raise your hand. I see Paul's hand is raised. There should be a button at the bottom that says raise your hand, or you can do it on the screen. But I think it's easier to and I'll come to you now. Just for the next webinar, what I'd really like to do is, doctors are taking strain financially in the private sector, emotionally, mentally with the stresses they're under wearing PPE. And really what I'd like to do is I'd like to put together a panel where we can talk about, we can make the next panel, just for the next one, less about treating the condition and more about treating the doctor, more about like actually how to support doctors in this time. I've got a great speaker who's going to speak on trends in the industry in terms of what they've seen in terms of claims, patients not going to the doctor, how to inoculate your practice, he's calling it, during this, over this COVID time. Mr. Louis De Silva from Healthbridge, and we'll get someone on the mental health side as well to talk to doctors about, you know, and also doctors who've had COVID on our collaboration to just share their experiences and the experiences of what they've been through. Because I think the important part here is that we need to support one another through this. So just that's just the heads up about where I think we should go for the next one before we come back to the academic stuff. We've explored this in detail. I'm going to just give an opportunity for anyone else to talk. So I can see that Paul's hand is raised. So let me cross to Paul, and then I'll just give maybe an opportunity for each of the panelists to speak one more time. So let me go to Paul, and then I'll come to you now, Prof. Merv. Go ahead, Paul. I think you're on mute, and you should be able to unmute yourself.
Dan, thank you, and to thank the panelists, to Prof. Merv, to Brian, and especially to Prof. Risch for joining us. I wanted to ask Prof. Risch, would you be prepared to post up the rest of the evidence that you were citing when we ran out of time? I'd be very grateful to be able to look through those papers and look through the data.
Actually, most of them are links in my 2 papers in the American Journal of Epidemiology. I have the links to almost everything. You just have to click on them, and they're all available. The second Brazil paper is not out yet. It's still submitted, but I can kind of release the abstract if people want it. I think that's probably okay at this point.
Thank you. And the Swiss that Swiss data, the graph of the 2 natural experiments you referred to in your paper.
So that one is in François, and there's been some question about the nature of the events, not the data, but interestingly, the people have said, well, Switzerland never banned using hydroxychloroquine, and that's actually true, but the EU did, and the Swiss seem to have followed. And so now we don't know whether the behavior change that occurred was due to the EU statement that the Swiss interpreted and took to heart, or the publication in the Lancet that was retracted 2 weeks later because people also started freaking out about that as well. So it's really hard to pin down the reasons why people changed their behaviors, and we don't really know because there's no survey done of what people actually did. So there's some question about the reasons why we believe that people changed their usage behaviors, switch them off and switch them back on. It appears that they did, but it's not proof. It's evidence. So I'm not relying on it as much as the data in the northern state of Pará in Brazil. That's very clear because we know that the medications were delivered and how it benefited.
So, Prof. Risch, just on closing words, firstly, from our side, thank you so much for being a part of this. I certainly know that Paul's very passionate about this topic, and we're very open to, you know, just delving into it more. And as I know, is Prof. Mervyn and all the others who have contributed. So perhaps we'll just make like an email group or a WhatsApp group or something that you can post onto, and we can just, you know, in the spirit of, you know, good opening our minds and at the same time adhering to evidence-based principles, you know, really go through the information more and more. Would you like to leave a closing message to everyone?
Well, I'll just thank everybody for your attention. Thank the other speakers for lively discussions. that we had. It's always, you learn the most when you have to actually defend your ideas. So I appreciate that. And it's been great to speak to you all. I learned a lot myself. Thank you.
Okay, great. Can I ask Brian anything that you'd like to say to like GPs out there you work with every day in terms of, just like, drive home messages for this week?
So to me, I think the biggest drive home message is that I think that this disease can be beaten in the pre-hospital setting. I think that's where the greatest impact can be made. Often by the time the patients land up with us in the intensive care unit, it's really difficult. The horse has bolted, and it's really difficult to get the horse back in the stable. And I think you guys have the potential to make potentially the biggest difference to the outcomes of COVID disease.
Okay, thank you so much, and Brian, thank you very much for spending your time and really adding to this. We do have a WhatsApp group that I'm going to add the panelists to, and then as they send information, I'll forward it to the GPs, and as well, we'll start I've got a few people asking how do they be part of this sharing group. Obviously GPs can just ask to be added to the group if necessary, if they want to be, and as well, we'll start an email list for future forums. So we're very happy to be collaborative and inclusive. But thank you, Brian, very much. Prof. Mer, anything for tonight? I mean, you're becoming a resident for us, but thank you. Would you like to?
Thank you so very much, Dan, and to all the great panelists and the information shared. What I just wanted to do was finally, before Prof. Risch in fact does go off, ask one further question that I think has particular relevance for GPs, and that relates to the use of azithromycin, because that's something that is broadly prescribed in the GP fraternity as well as in the hospital fraternity. What does he think the true benefit of azithromycin, if anything, actually is in this companion medication, or utilized alone? I really would be very interested, and I think it would be of massive benefit to the group that's currently on to hear his sentiments on that.
So I wish I knew. I think that you're right, that there probably is some benefit on its own, that it's worth exploring more. We need better evidence for this, but even in patients who don't get hydroxychloroquine, that azithromycin may have some utility. And it's very well tolerated by and large, and it's a short course. And it's not, see, I think that what we need to be doing as outpatients is basically everything that's safe to give, we should throw at the patients. Brian Proctor in Texas does that. He's got about 6 or 8 things that he uses, including CBD oil and vitamins and so on. And he gets great results. And, it's his recipe that he's not willing to change. So I think that, we really don't know what's going to be best. And I've never actually said there's only one thing that works. I'm very empirical, and my approach is try everything that works and then figure it out, as you best you can. And so azithromycin seems to have antiviral properties. So does doxycycline. Whether that it's because there is a latent chlamydia infection that they're actually treating that becomes activated with the SARS-CoV-2 infection or not. People have hypothesized that. I don't know if that's the case or not. I think that mechanisms are great. I love biological mechanisms for reasons to study things, but give me the human data. That's what I really want to see before I know what's working and what's not. So I can't really give you a good answer yet.
Right. No, thank you very much. I mean, I think obviously people have put through tons of postulates. I mean, possibly one of the issues where it may be having some benefit is its so-called quorum sensing or anti-inflammatory properties and immune modulatory properties. It's probably not bacterial. I think the viral issues are once again very questionable. And in fact, having chatted with Dr. Zelenko initially, he said he thought up front it may in fact have been concomitant bacterial infection, but we know that that generally isn't the issue up front. So I would just, as a matter of surmise, say whatever benefit there might be may be coming from its immune modulatory anti-inflammatory activity, but once again, the early enthusiasm, I think, has waned a little with azithromycin.
It's true. It's not a strong benefit, but you see the benefit first and you figure out why later.
Okay, guys. Thanks. I think we could go on the whole night, but we really, and all day, depending where you are. But thank you very much. Just a few things for the doctors are still on. Some of the projects that we're doing are, we've got a Facebook page. Please encourage patients to come to it. It's called the GGPC Facebook page. As I said at the beginning, Dr. Karen van der Merwe started the GGPC. She's on tonight. She is a collaboration of GPs. And on this Facebook page, we do articles that's basic patient education about coronavirus, risks, masks. We've got a few editors who are very active on it, and you can see that there. And we're asking people to contribute as well. If you want to share information, please do. If you want to get in touch with the GGPC, all the information is on the Facebook page. And any primary care doctors who want to be brought onto the group, also there's a WhatsApp button there. You can click on it and we can add you on. We will email you about the future ones. There's also a doctor support group for doctors who have had COVID, particularly GPs, but I don't think that'd be, we'd turn away anyone else. And Dr. van der Merwe is involved in running that. And so please, if you'd reach out for those things. And thank you so much to everyone for being involved. Really great to be with you all. And at the next one, like I said, we will have some just general chat time and look at a bit of a different focus for a while. And every couple of weeks when you do these things, hopefully they're just a bit of strength to all of us. So thanks for staying on as late as you have, the 200 people you have, and have a good night. And we hope it's a good week for all of us. And thank you to Prof Karim in his absence as well for making himself available for so long through this thing, and for his talk at the beginning. So thanks everyone.
Thanks everyone.
Ciao.
Thank you, Dan. Thanks, Prof. Risch. Thanks, Mervyn. Bye.